Well, I have the esteemed Dr. Neil Patel here to help me out today, but we'll talk about a little bit about how we do some SI joint fusion surgery, and we're going to use pure fluoroscopy for this. And there are other techniques that are pretty easy to do using a navigator technique. And I encourage you guys tomorrow when you're using some of the Stryker labs with the navigation or the Globus to try and just look at these pathways with navigation versus just fluoroscopy, because it'll really make this technique stick. So. With that being said, we'll kind of start off with a fluoroscopically guided SI joint fusion. So to start off, I trace out for a starting point the PSIS on the top of the pelvis. So we have a straight down view here. So you can zoom out just a little bit. So this is PSIS. This is the long axis of the femur. We draw a line and divide those into thirds. And the reason I do it this way is because as the pelvis sits here, this is kind of how the pelvis is resting as this patient is lying here. This is a never event. This is in the greater sciatic notch. Here's obturator framing. This is also a never event. That goes in the belly. So right in this area here is pretty darn safe to put a pin to start off with your starting point. So after I draw that grid, we have an outlet view and an inlet view. And these are kind of real basic trauma views that help us identify where we are in the sacrum. So on the outlet view, let's take a shot there. So you can see that I'm going to kind of start here, and I'm going to go right into bone. The shot there. Okay, so I'm too cranial, and so I'm going to slide caudal. And so as we slide caudal, you'll see the next view is going to be somewhere right around here. Shot there. Good, so too far, caudal. So if you keep navigating away, going back to different views, you'll be able to go to your regular starting point. So let's try going to the inlet view once. So let's slide the C-arm to the inlet view. And so usually this step sometimes can take a few minutes as you kind of go back and forth with your inlet and outlet views. Dr. Patel and I did a little cheating, and we navigated our starting point before we started here, so we didn't spend 15 minutes getting the starting point. So it's going to be somewhere around here. So let's take a shot there in the inlet view. Let's go cranial with the fluoro. Let's take a little bit out of it there. Okay. The inlet view, and you'll hear a little bit more about this with my talk tomorrow, but the inlet view is predicated on having your S1 overlying S2. And so here I want to aim posterior. So in line with my outlet view, I drop our hand, shot there. And now we're going to slide the pin a little bit anterior. Okay. Shot there. Let's go a little more anterior yet. Shot there. Okay. You can kind of see my little track down there. But now we're going to go the other view and verify. Let's go to the outlet view. We'll verify cranially and caudally that we're where we want to go. You can see the indent on the screen there of where L5 is resting, and it's coming directly anterior to the sacral ala. And in this view, as we go caudal with the C-arm here, we're going to see, hopefully clearly, the S1 foramen. So let's do one more shot. So you can start to see the S1 foramen. It's a little bit hard to see, but you can see, I'm going to point at it with my guide pin there. So shot there. Shot again. So if I kept on going right now, I would be hitting the very top of the S1 foramen. So we want to go, I always call split the uprights. So we're going to go aim a little bit cranial here. So shot there. Good. So we're going to go right in there. And once we like our starting point, then I take with the 3.2 millimeter guide pin. This one is purely to find your trajectory, and then I swap it out for the 3.2 millimeter guide pin, and I go right into the hole. And then I take my power, and on oscillate, and an important point with any pelvic surgery is that whenever you're putting in a pin in the pelvis and in the glutes, it is always done on oscillate to prevent binding up any of the tissues in there. So on oscillate, shot there. Okay, we're all the way in, the starting point, into the middle of the vertebral body of S1. So let's verify on the inlet view that we're in the exact same place we need to be. Once I'm at this step, I take a depth gauge and I measure what size screw we want to put in. So I'm down on the ilium and we're measuring an 80. Okay, so I'm going to take an 80 implant so the team can start preparing the 80 implant with some bone graft. And we'll show that in a minute. So let's take a picture there. Let's go north on the inlet view there. So let's take a little bit out of it, and let's slide straight north. There you go. Let's take a shot there. Good. Let's go a little bit more north if we're able to. Just a little bit. Okay, shot there. Wonderful. Okay, so this is not the greatest inlet view because you want to have that S1 and S2 body directly superimposed to get that density right in the front. But this looks pretty good. So once we're at this stage, we take a knife. Where's that blade? There we go. All right, and then I increase the size of my incision to be about 5 or 6 centimeters, as I found about all you need to do on the glute there. Then we want to get the fascia out of the way, down deep, so I slide this directly on the pin. I usually use an 11 blade to even minimize less soft tissue damage, down to the ilium. Once I'm on there, we hand the blade back. And I just use my finger to bluntly spread the gluteus maximus, medius, and minimus so that my finger's right down on that lateral ilium. And once I can feel that, I know we're in a good spot. Then I take my sequential dilators. We just dial up like any type of tube-based MIS system. We dilate, dilate, dilate. Once we're all the way dilated, right down on the bone, this device embeds into the ilium, and all we're trying to do is just maximize our safety without having anything move. So once that's on the ilium, we kind of just gently tap that into the ilium. Okay, then that comes back, and then we're going to take some stabilization pins. That wire stays in. There you go. The stabilization pins just simply lock everything in because, again, all of us are about avoiding complications. And so this just kind of goes into the ilium. Okay, and another one. This goes on the other side. Okay, once we're at this stage, then we have this working portal, and this one is how we adjust our depth. And so we'll put this all in, and then I can adjust if I want to go 5 millimeters in or 5 millimeters out. This step is just make sure that I'm actually decorticating the SI joint. So in the system that I like to fuse SI joints with, we decorticate and get rid of all of that intra-articular cartilage and then bone graft it. So we take our drill in there, and then on fluoro, let's take a shot there. Good. We're going to go, let's pull back a little bit with fluoroscopy. And I go all the way and swallow up my pin the whole way. Let's take a shot there. I'm going to go a little bit farther and swallow up that pin. Shot there. Good. Okay, so I'm all the way in. So now I'm going to take it out. Now you'll see it in my drill bit. I have all sorts of bone graft in here. So this is kind of the first aliquot of bone graft we're going to get. And I'm going to put that pin, see if we can navigate that guy right back in that hole there. Now this is, if you have to pick, let's go to the outlet view. If you had to pick the second critical part, being the first one, getting your pin there safely without touching L5 and S1, the next part is going to be getting our 12-5 drill bit to the SI joint and then measuring or finding out where our SI joint is. And as we come down here, we'll see exactly where that is on fluoroscopy. Good, and let's push in just a little bit. Let's see, my pin, there we go. Okay, let's take a shot there again. Shot again. Okay, so now I'm on lateral ilium. So on essentially high speed, I'm going to go and I'm going to feel the SI joint next. So one cortex going in. Okay, that big sound right there is the iliac side of the SI joint. So take a shot there. There, so that's the iliac side. So now I'm going to rotate my guide back till I get to this black laser line on the drill bit. Now I know that's centering me up somewhere on the SI joint. So now I'm going to go across the SI joint. So the next thump I should feel is the sacral side. Shot there. I'm going to go a little bit farther. This patient actually does have some sclerotic SI joints. There, that little thump right there, that's the sacral side. So I go in a little bit farther with my depth gauge. Now I'm on the sacral side of the SI joint. Now I'm going to go slowly and get some bone graft from the sacral ala. And slowly as I push, I come back out. Now all of this is autograft that is collected from within the sacral ala and the ilium. So all this is good graft that we put in our implant to autograft it. So next stage, we have our decorticator. And so as I turn this device back and forth, I'm scraping out all of that SI joint cartilage, and it gives us a little bit more bone graft. So I've got to give myself some counter, and I push, and let's take a shot there. Now you'll see a cutout. That is the apex of my decortication. So I'm going to actually go in just a touch more. Push, and now we're just going to rotate around, and I'm just going to start really scraping out all of that cartilage, all the subchondral bone. So ideally, we have bleeding subchondral bone on both sides of the SI joint. And you can really kind of hear it grinding inside there. And if you want to see where you are, you can always take a shot once in a while. So let's take a shot. Yeah, good, all right. So go round and round. Ultimately, we're going to get it all the way out there, and then you'll see kind of what it looks like when we get it out. So let's take a shot there once. So you can kind of see it going out there. And then, because of our cadaver, we're losing a little bit of a grip of that first tool inside the SI joint, but you get the picture of how that's supposed to work. It goes up all the way around. Shot there. Good. And now once you're going all the way up, and you're going all the way down with it, when you go round and around, I'll show you kind of what that would look like on the caudal side. Let's take a shot there. Good, so we want to go a little bit more farther in. So one thing I've started to do a lot lately is I usually go 5 millimeters in and 5 millimeters out to increase the depth of our decortication inside that SI joint. That just increases the volume of graft that I can inject, and it also allows what I would call more of an area of true arthrodesis going across the SI joint. So let's do a shot here once. Okay, and then let's do another shot here. I always just kind of do these shot, save, shot, save. So if we can do a live fluoro once, so as you watch with live fluoro, as this is going around and around, we're really kind of just ripping out the whole SI joint. Okay, stop. Good. So once we are out to fully extended, which in this patient, we didn't get the template, but usually it's about 30 to 40 millimeters of diameter. We retract our decortication device. Then, we're not going to do it here, but usually I kind of see the suction device. Usually I'll take this, well, I always do, and this is just the suction device, hook it up to suction, I put it in here, and I irrigate out through this hole here with irrigation, and then we suck out all of the bony debris and create a big bony void inside there. So after that, all that debris is removed, we take our bone graft applier, and then what happens is when I put this all the way into the SI joint, what happens, all this stuff right inside here squirts out in the SI joint to create a huge autograft zone inside there. So that's kind of what that would look like inside the SI joint. But we'd simply put that all the way in there, and I'd deploy it inside there, and I'd pull this back out. And at this point, I take the first dilator that we had and a guide pin, and then we, because all this device is all cannulated, so this goes in here, and then take the 3-2 guide pin, and that goes right into where we are, and I always verify that we're where we want to be. Let's take a shot. Oh, is that our current shot? Perfect, okay. And then, now I'll take the wire driver empty, so I take everything out except that protective trocar. This usually has some clot on it. There's that one, and then we take our anti-rotation pins out. Here's one pin back. Here's the other pin back, and then we'll load the implant up on power here. Yep, that's perfect. All right. And this is the implant. This is always usually filled in with bone graft in here so that the fusion goes through the implant. This is a lag portion, so it squeezes the SI joint together. And I'll talk a lot about these philosophies tomorrow during my SI joint talk. So let's take a shot there. Good, now I'm gonna go in about 75% of the way in. Shot there. Okay, now what we do is we're gonna come to an AP view with a 20-degree roll back. And now the pelvis is sitting there like this. And so we want to look right down that lateral surface of the, kind of that 3-2 back. We're looking down the lateral ilium, and that allows us to ensure that the washer is sitting flush up against the ilium and we don't over-compress. All right, let's go a little bit more north and then take a shot when you get that 30 degrees of roll back. 30? Yep, 30 roll back. All right, looking good. And then once we're about down, leave the pin in, I take this guy off, and I use my finger to go ahead and clear out any fascia from underneath that washer so we don't entrap any gluteal fascia. So let's take a shot there to see where we're at. Good, and let's push in just a tiny bit. Okay, good. You can kind of see the lateral ilium, and you'll see my washer dock up against that. Shot there. Perfect, okay. So now my washer's flush here. Now I use sequential kind of shoot save, and I watch the SI joint compress. So, all right, take a shot there. Okay, I'm gonna do another couple quarter turns. Let's do another shot. And we'll keep on going here a little bit. Another shot there. Good, so we're starting to see kind of continue to see that washer dock, and then as you keep on going, I mean, this is extremely tight. Shot there. Good, so you can kind of see how everything in there. If you go too hard on some patients, you can actually intrude the ilium. Shot there, which we're just seated and we're kind of just at that margin right there. So there you go. So I don't know if I'd compress any more than that. Shot there. There you go. So now that's down. Let's go to the inlet view. So now you can see you can go to the inlet view that we had before. Now there's a concept of anti-rotation when you have two flat boards. If you put two screws in there, it'll help prevent rotation. This patient and others, the iliosacral articulation is typically tongue and groove. And when you compress tongue and groove decking, that instantly gives you stability. So this patient is already compressed and locked in because we compressed against this tongue and groove type of articulation. However, I think just to provide a little bit of added insurance policy, we put in an anti-rotation screw below it. So it's guided. And if you're on the inlet view, on a non-dysmorph, we're going directly below the sacrum, and I shouldn't be able to see this pin. Shot there? So that indicates to me I am directly underneath this implant going into the junction of kind of S1 and S2. All right, go to the outlet view, please. Now we're on oscillate, outlet. Oscillate, we're going in just a couple centimeters or so. The danger with going in too far is we're likely aiming right at the caudal aspect of the S1 foramen, which is kind of what we had expected. So we're going to go in another couple centimeters. Shot there. Good, and actually in her case, it's big enough I'm going right above, so that's pretty, this is always a nice thing to have happen, pretty safe. Now we're going to measure, and we're measuring a 45, so I'll put in a 45. Let's take our little punch drill or a step drill. Not every single patient in my practice gets the anti-rotation screw, but it's just a little bit of an insurance policy. Okay, let's take the wire or the drive there. I'll put this guy right on the top there, put it over. I always want to reverse, I want to bind up any soft tissues, then just go gently on forward. And then I always double check and make sure I'm not advancing this pin into the foramen. So let's take a shot there. Yeah, looks good. And I withdrew it a little bit just to make sure it didn't happen. Shot there. And I always do final tightening on hand. Again, just to make sure I don't violate that lateral ilium.
And what's the width of the anti-rotation screw?
6.5 millimeters.
Okay.
So so oftentimes, like with Dr. Sebastian and others, when we combine this, let's take a shot there. Good, so that's our final construct. But I don't put the anti-rotation screw in because it's only 6.5, and if I combine these, let's try the inlet view. With a long segment fusion, let's draw the inlet. The iliac screws that we put in are like 8 and 9 millimeters, which are way bigger than the 6.5 I'm using. So that is the anti-rotation control when you combine this with a long segment spine fusion. So if I'm doing an isolated primary, I'll typically add on the 2. So there we go, and that's what it looks like.
And the width of the other screw, the fusion?
The primary implant is currently 12 millimeters for this patient, but if their anatomy is best suited for a 10, we have that. There is a 10, and there's also an 8 that's going to be developed to try and get under S1 pedicle screws that are pre-existing. And the whole concept with this 12 and the 10 and 8s is to try and bite the good bone of the vertebral body of what I would call the upper sacral segment, where the bone is densest. The bone laterals, you can kind of see in that fluoro shot there in the ala, is really just vacuous and doesn't really allow any type of good purchase with an implant. And that's where, we try and avoid loosening. And some implants out there stop in the ala, and we kind of published this and looked at it, but that's where the least dense bone is. And so my philosophy is to grab that bone and squeeze and compress it together.
Nice. Cool. Any questions for Dr. Cross?
I'll just say P. Come this way.
But I'll be here, obviously, for the rest of today. If you have questions, and I'll give my talk tomorrow on kind of SI joint fusion from my perspective. And we developed quite a SI joint clinic for primaries and revisions at Mayo Clinic. And this system is sort of built to accomplish a good primary, but also to be able to answer questions with revision situations where there's not fusion in there and there are loose implants, and you got to take away that sclerosis from the loose implants. So
nice.
I love talking about this stuff, so I'll be around, and please pull me aside if anybody has any questions. But my stomach is growling currently, so we can break.
All right, sounds good. Thank you very much. That was great. So next up is lunch, and